Last episode, we talked about colon cancer in the context of screening, prevention, certain treatments, general information that people need to be aware about, especially given that this month is Colon Cancer Awareness Month. Now we're going to switch gears a little bit. I'm going to bring on a person who is a colleague of mine who actually personally faced a diagnosis of colon cancer. Just like we did last time with breast cancer, you're going to hear a personal story about somebody else's journey with colon cancer, their diagnosis, and the steps they took to combat the disease. And I need to stress something here. Her story is going to be very personal. And just like the breast cancer survivor story that I hosted a few months back, not everybody with this disease is going to have the same outcome, the same treatment options. This is designed not to scare you, it's designed to give you hope, but also to encourage prevention as a primary means of detecting a very fatal disease, a disease that is rising in younger and younger people. Kristina Dhillon's story is mentioned in Forbes magazine, and I'm going to link into the description of this episode so that you can read her words for yourself as well. I'm Dr. Mark Papadakis, nobody particularly special, just another freaking ER doctor. And this is the JAFERD cast. Let's get to it. All right, I'm back and we're here with Dr. Kristina Dhillon. Kristina, thanks again for joining me. How are you?
Good. How's it going?
Pretty good. So Dr. Kristina Dhillon, she and I went to medical school together for at least the first 2 years at Toro College of Osteopathic Medicine. And then you went to, where'd you go after that? Tell us about your post.
I actually ended up transferring to Western University in California, Southern California. So that's actually where I have my degree from.
Okay.
And then after med school, I went to residency at Arrowhead Regional Medical Center, and that's in Colton, California.
And you did internal medicine, is that right? Is that what you do? That's what you're practicing in right now, internal medicine,
Correct.
you're a hospitalist, and you're still in Cali.
Yes. So I live in Southern California and I have a private practice. It's a direct primary care practice. And I also work as a hospitalist as well.
What's your name of your practice?
Exordium Medical Group.
Awesome. So, the whole focus of this topic today, it's March, where it's Colon Cancer Awareness Month, and you yourself are, I guess, I'm going to count you now as a survivor of colon cancer.
Yes.
Because you were tell us, you were diagnosed, what,
in
last year?
technically March 2025. So it's going to be 1 year shortly. Actually, at the end of the month, I was diagnosed 2 days after my 40th birthday. So it was not the greatest.
So tell us about that, because I saw, so you have how this came about is you have actually an interview in Forbes magazine
Yes.
that you talked about your basically journey, not just with colon cancer, but also beforehand, because you have ulcerative colitis. Is that
Correct.
right?
Yes.
So let's kind of start, I guess, with the ulcerative colitis diagnosis, because you went through medical school with ulcerative colitis, which is really not an easy thing to go through. I mean, that's one thing. So when did you get diagnosed with ulcerative colitis?
I was diagnosed I was 25. So I actually, I never really, I never missed a day of school, never missed a day of residency work. It was pretty, you'd have like a flare up here and there, but it was, I'd say pretty well, like, controlled symptom wise. I'm pretty on just oral medications. And after 8 years, you get screening colonoscopies every year, because when you have IBD, you have a higher risk of colon cancer. And so I started doing that and things just seemed fine. They never really recommended escalating therapy. And then I had 2 children. So before I had my first son, I had my screening colonoscopy, everything looked good. So I always try to make sure, like when, with like family planning, that I was like up to date on everything, because when you're pregnant, it's, a long time and difficult to get those kind of things done. So everything looked fine before my first child. And then I had him, and then I had my second child, about 2 years after. So I had another screening colonoscopy, because so typically you get it every year after 8 years with IBD, but because mine looked okay, the GI at the time said I could stretch it to 2 to 3 years.
Okay.
So after my first son, I ended up waiting like, I think 2 years. And again, everything looked fine before I got pregnant with my second son. And then he said again, oh, you could go like 2, 3 years. So then after my second son was born, I didn't have my next screening colonoscopy until about 2 years after that. And then I went to a new GI because my other GI retired and she found a lot more inflammation. I didn't have any symptoms, so it's kind of difficult because a lot of times I know GIs sometimes will like escalate therapy, not just on like what the colon looks like or what the pathology looks like from the biopsies, but also your symptoms. And so I didn't really have any symptoms. But she went in and then she's like, "Oh, you look really inflamed. So let's escalate the therapy." Because at the time I was just on oral mesalamine, which is pretty basic. And then she switched me to a medication called Stelara, a little bit stronger. That calmed the inflammation. And then she said, "Okay, I want to make sure everything looks okay because you don't really have any symptoms. So it's not like I can really go off of, oh, well, your symptoms are better. So the drug's really working." So she's like, "Let's have you come back in like 3, 4 months and see how the drug's doing." And so that's all the inflammation calmed down and she was actually better able to see certain areas that were really inflamed and then she was able to see this lesion. It wasn't a mass. It
Hmm.
was extremely small. She actually said it just looked like a tiny, like a pinpoint, like dimple. And so it
Interesting.
was really hard. It could have been easy to miss, especially with all the inflammation she said. So it was a good
I
thing
was
I
gonna
wasn't
s-
Laura.
I was
So
gonna say, so basically the inflammation was probably hiding this lesion the
yeah,
first time around, and then they
yeah,
need to calm that down, and then subsequently here we are. So it wasn't like a huge fungating mass or anything like that, you
it was
know?
very tiny. Yes, I was very lucky because so then she was trying to do it's called an endoscopic mucosal resection where they inject like a saline solution or some kind of solution between the submucosa and the muscularis, and then they can just remove the lesion. And so she was able to separate it, but she was having a little bit difficult time with I think her loop was not able to like adequately grasp the tissue. So she's like, I don't want to disturb the area and cause difficulty, I guess. So she ended up sending me to a specialist at a different, like an academic center, and he does ESD, um, the dissection, the endoscopic submucosal dissection. And so she's like, let's have you go and be evaluated by him and see if he can just remove the whole thing. And she's like, it's probably nothing because it doesn't really look like much, but just because of your history, let's not take a chance. And so I go, and then when he evaluated it, he said that he didn't think it looked too suspicious either. And he actually ended up just doing the EMR. So that's a little bit more superficial than the
Hmm.
ESD. And then he's like, oh, don't worry about it. It's probably going to be fine. And then he calls me up on his cell phone at like 7 a.m. a couple days later. He's like, I'm sorry. It actually, surprisingly, it's actually adenocarcinoma. And I was like,
Hmm.
it was like, I don't even think it was 7 o'clock yet. It was so early in the morning and I was just
I haven't even
shocked.
woken up yet. I mean, too, you're getting this
Yeah.
phone call, you haven't woken up, and all of a sudden it's like, hey, by the way, we think you have colon cancer.
Yeah. I was like totally shocked. But thankfully, like the initial path, like from the biopsy, I guess, it was, very low grade. Like there's, I think, like no tumor buds, and it looked like it was early even then, but
Hmm.
obviously super scary. So the next step for somebody with IBD with colon, like a colorectal cancer, you have to be evaluated by a colorectal surgeon. Because some people, like if you don't have that IBD history, they have maybe not so invasive ways of treating it. Like they could just maybe resect that portion. But for
Hmm.
me, I had to have a total proctocolectomy where they take the entire thing out
Ow. Okay.
because you assume if you have that there, it's probably going to
It's probably
happen in
elsewhere.
another.
Yeah. Let's go back because you basically had the colonoscopy. Your original GI doctor says, okay, there's something here. The inflammation calmed down. We see something. We kind of took a little bit of it. I don't know, but we didn't want to disturb it. And so they woke you up. So you're now like, in recovery says, hey, we found this thing. It's probably nothing, but you got to go now see this other doctor, the
GI,
more
yeah.
specialist. How long did that take you? What's the timeline between that test and the
The next
specialist?
one?
Yeah.
Oh, yeah. So I had that one, I believe, on March 12th. And then I had the follow-up, like with the specialist for the ESD at the academic center.
Hmm.
That was exactly 2 weeks later. So it was like
Okay.
on the 24th. So
So
it's
pretty
actually
quick.
pretty
That's
quick.
good. Yeah.
And then I had the diagnosis on the 28th. So a couple days later. And then that was a Friday. Horrible to get a
Of
diagnosis on a
course.
Friday where you're
Yeah.
festering over the weekend. And then, but I was able, because of my like, I have like wonderful colleagues at the hospital I work. I know a very good like colorectal surgeon, multiple. and another surgical oncologist. I called them like right after I got off the phone. I was like totally freaked out.
Hmm.
And they were like, don't worry, we're going to take care of this. It's going to be okay. And they referred me to one of their colleagues at City of Hope. And he's like just like he's like an authority in colorectal surgery. He's very good, like renowned surgeon, and particularly for the type of surgery that I was going to require. So that's I was in his office on a Tuesday, and I
Wow.
had a first appointment with another colorectal surgeon on a Monday. So I met with two different ones, but I ended up
Okay.
going with this colorectal surgeon at City of Hope.
Okay. All right. And
Yeah.
then ultimately, so you had to have this procedure done. How long between that meeting and basically the surgery to have this done?
So I believe I saw the colorectal surgeon. I think it was like April 2nd. It was a Tuesday, and then I was scheduled to have they have to do imaging. You have to
Yeah.
do labs. So I had all the staging done, and so initial staging, everything was kind of pointing towards like an early stage one. But the problem with it was technically rectal cancer, so those ones are a little bit difficult with even imaging because sometimes you can have like, I had MRI with contrast, CTs with contrast, abdomen,
Hmm.
chest, abdomen, pelvis, whatever. And even though the lymph nodes, there was nothing enlarged, sometimes the cancer is so small, the lymph nodes can be as small as like 3 millimeters sometimes, and that's not going to really pop up. So even though the imaging looked good, you really don't know the final path or you don't know your staging until you have your final path back. So it was, like, reassuring that the labs and imaging looked good, but it was still really hard because I wasn't gonna have that final answer till after the surgery, which took place on April 30th. So
Oh,
within
wow.
about a
About a
month,
month
everything was kind
later.
of dialed in and
Yeah.
dealt with.
Okay. And then what the recovery looked like for you? Did you have like a colostomy bag, or like how's that
Yeah.
looking?
So how it worked was I had the total proctocolectomy, and it's called an ileoanal pouch anastomosis. It's like IPAA. It's a J pouch. So essentially, they take the small, like the ileum, and they create like a new rectum, if you will. And so while it's a big surgery, I think it was like 6 or 7 hours,
Wow.
and so
Phew.
they remove the whole colon rectum. They do this reconstructive surgery. They anastomose it, and then it has to heal. And so I had to have a temporary ileostomy for 2 months while that healed. And then after 2 months, I was able to have that basically taken down and then everything kind of reanastomosed and, um
Wood so far, so good. Things are working as they should.
yeah, I mean, it was the recovery. Interestingly, I feel like the recovery from the actual, like, I call it the Mac Daddy surgery, like the big one. I recovered really fast. Like with the ileostomy, I felt great after 8 weeks. So the week I was scheduled for my like takedown and reversal or whatever, I felt wonderful. Like
Hmm.
I had tons of energy.
Wow.
I could have gone back to work. Like I
Yeah.
felt great. And then I had the takedown, and then that was like, interestingly, even though it was like a smaller surgery because it was only like maybe an hour long, I'm still recovering. I don't know. I think that it's been a difficult recovery in terms of like a lot of like pain. I don't know, like pelvic pain and stuff, but I have another colorectal surgeon who specializes in like pelvic floor dysfunction, and so she's helped, like, you can do like Botox, and it helps with like relaxing all of your muscles and like the pelvic area. And so that's been really helpful. But yeah, it's been a slow recovery, I'd say. I don't
And
know.
all in the
I don't think
process,
that's typical.
and you're still basically being treated for ulcerative colitis too. Like you're still taking the medication, everything else on
No.
top of. Oh, you're done.
I'm not actually. I mean, because I've had like endoscopies since I've had the surgery to check on the reconstruction and everything, and they said everything looks good. They don't really see any inflammation, and
Wow.
the colon, there's like residual like rectal tissue left, like I think 2 centimeters. But every time I've had, I think three so far since the surgery, and they said it's looked good. So I actually go again in April. So we'll see if it still does. And sometimes
Wow.
people do. I mean, you're not wrong. Some people still need to take medication even after the surgery. It just is a case by case basis, I guess.
So then let's go back because you mentioned about your symptoms, that you had no symptoms. We talk about rectal bleeding as a big one, but what else? What other symptoms? Because with ulcerative colitis, you have flare ups, you have pain, things like that. So that's not really a good viable symptom to go by, really. And you may have bleeding too. So what have you looked at personally for ulcerative colitis as a symptom that raises some red flags?
Well, kind of what I was mentioning earlier, I was pretty well controlled. So I didn't have any bleeding. I didn't have pain. I didn't have any like changes that would be even alarming. I actually had zero symptoms.
What would be
Um,
your symptoms though? So let's say if you were like having a like what would be a red flag that, oh, you really got to get a colonoscopy
Like
sooner
if
rather than
oh,
later?
okay, yeah. So, yeah, I mean, like, if you have any, like, blood in the stool, even a drop, it's not normal, it needs to be looked into. Even people always chalk it up, "Oh, it's like hemorrhoids," but maybe, but you don't know until you look. And sometimes, change in stool caliber, like, if it's really thin or any changes in shape that's abnormal to what you're used to. Maybe if you're having diarrhea, if it's been lasting, like, several weeks and like, that's weird," and outside of, like, an illness or new constipation, even bloating or acid reflux, any kind of GI symptom that's new that for you, that should always be looked into. You should
Yeah,
always go to your
and
doctor.
there's I mean we talked about this last episode too about the rising rates of colon cancer in younger people too. One of my colleagues, her husband unfortunately passed away of colon cancer and he was 35. And again, he had GI like symptoms. It was, new bloating, it was nausea, it was pain, it was a lot of different things. It was like this is weird. So he went to get checked out and that's when they found by that time, unfortunately, it had already progressed to, stage 4. I mean, it was just, everywhere. And they're looking apparently, and your Forbes article mentioned this, colon cancer rates on those under 50 are expected to rise 3% annually. I
Mhm.
think they said by like 2030 or something like that. So
Yeah.
um, I don't know. I mean, we're both physicians. I posed the question to the GI doc that I spoke to last time, but what is it about? Is it something in our lifestyle, our diet? What is it that is causing these rises? I don't know.
I think, people are still looking into it. I mean, I know there's a lot of energies, trying to go towards figuring out the why. I think we can speculate that it's probably I think a lot of it's environmental, and I think that there's a lot with the gut, like, microbiome that I think that we still need to learn more about. They're linking heavy processed foods at a young age, like childhood until adulthood, increased rates of IBD and colorectal cancers with that. So I think and obesity, there's a
Yeah.
lot of things that I think can contribute, but I think that it's probably a combination of things, and so it's hard to really pinpoint. But I know for me, I grew up on like processed foods, like
Hmm.
looking back, it's all I ate actually from a young child, like little, until, I mean, I didn't really eat all that healthy until I was an adult.
Yeah.
So that's a long
And
time of,
by then, you're diagnosed with IBD as it is, so that you almost had to force a dietary change to some degree, I would think.
yes, but I wasn't the greatest. I still ate too much fast food and processed food, and you just, you think you're invincible. Like I'll be all right, and I think that we all kind of fall in that sometimes where you don't think, "Oh, it's not gonna happen to me. It'll be fine."
Right. And then
You
all of a
know?
sudden, here we
Then one
are.
day it is.
Now, does your diagnosis guide or in some way inform how you treat your own patients, both in the hospital setting and in your primary practice? Do you look a little bit closer to people with GI symptoms? But let me caveat this. For emergency physicians, when a case goes wrong with us, that sticks in our mind. So we just
Yes.
have a heightened sense of awareness about a diagnosis that we tend to look for a little bit more in other people who normally you would think that, oh, that's not really a thing in this population. Do you think that's happening to you? Do you look a little bit more closer to people coming with like GI complaints or anything like that?
Yes and no. And the reason why I say no is because my husband and I both, like, before this all happened, we've been such sticklers about prevention and screening. We're just so hyper about that with our patients. I always, like, my quote with everybody, all my patients: "An ounce of prevention is worth a pound of cure." I literally say that to everybody. And because there's people that they're so hesitant to do maybe mammograms or colonoscopies. And so I spend so much time educating them on, the pros, the cons, the alternatives. And I've always really done that even before this. But I think now I'm a little bit more heightened with any GI symptom. I'm like, oh, wait, we got to look into this, like in
Yeah.
my mind. But, or as particularly family history, because I think that people tend to kind of dismiss that. I don't think a lot of patients don't realize how impactful that is. Like if you have, like I'll sometimes have people come in and they're like, multiple, oh, my aunt, my grandma, my cousin, this, have had colon cancer. And I'm like, okay, well, you have to get a screening colonoscopy.
Yeah.
They may have never been told that until then, and they don't understand, but they're so, but it's not my mom, it's not my brother, but it's like if you have multiple second degree relatives, that still counts actually as a first degree.
Were there any insurance hurdles that you ran into getting
Interesting.
screening and testing?
Okay, that is interesting because I know that insurances with our own patients, like we don't, with direct primary care, we don't actually bill insurance. It's a more of a membership based model, but we still deal with insurance for like, prior authorizations, like say if somebody needs an MRI, whatever. And I experienced zero issue. They
Wow.
covered everything right away, stat urgent. And I was so shocked because I hear these horror stories where people like care is delayed.
Hmm.
Now, and I don't know if it's just the type of plan I had. I had it through my employer through the hospital. Well, it's technically a hospitalist group. And I don't know if it was just a plan that I had through them. It was a PPO with HealthNet. And I honestly, it was a really good experience. They did not deny a single thing and nothing was delayed. It was very seamless, actually. And it made my life,
Million times
I mean,
easier, I'm
I'm telling you,
sure. Wow.
yeah. And there were no real big surprise bills or anything. And then I just switched my employer at the hospital's group I'm employed by, I should say. They switched to a different insurance. It's Blue Cross PPO, but they're already like just some simple stuff they've like denied. And I'm like, this wouldn't have happened with my
Hmm.
old insurance. Cause
Yeah.
like, so that'll be interesting to see how it goes. So I'm really very fortunate that I had the insurance I had when I had all that going on, like the big stuff, like, this massive surgery and all these scans and, different specialists. And so I don't have anything. I have only positive things to say about my experience with that, which I know is probably a minority, but I'm very thankful that it wasn't a bad
And
experience.
is HealthNet its own like insurance company? It's not run by like United Healthcare. It's not a subsidiary or anything like that, as far as you know.
I never looked into it. I'm not real sure.
Again, like I'm not saying you should have. I'm
Yeah.
again, it's out of curiosity because we hear the horror stories, like you said, about people getting denied care, delayed care.
Right.
You have, I mean, United Healthcare is kind of the big bad in a lot of this stuff. A few years ago, they tried to change the prudent. They were going against the prudent layperson rule when it came to emergency room visits in Georgia. The idea that United Healthcare wanted to bill the patient based upon was it emergent or non-emergent,
Mm.
based on the final diagnosis. So you came in for chest pain, but I put a diagnosis of, gastric reflux, they were going to try and come back and say, well, that's not emergency room care. We're not going to actually pay that. And there's a lot of hemming and hawing where basically it's like you're going against what's called the prudent layperson law, meaning that you have no idea your chest pain is a heart attack or reflux. That's up to me to decide. So why are you punishing the patient for basically being a prudent layperson and getting this thing checked out? Thankfully, that was very short lived.
Okay.
That got struck down. But again, you have these companies like United Healthcare trying to, save a buck or two. And
Yeah.
really, it's at the expense of the patient. And already you have somebody who has a history of colon cancer,
Hmm.
IBD, surgery, suddenly getting, delays or denied by Blue Cross. It's like, well, what do you want to do here?
Yeah. Yeah. It is kind of interesting. So we'll see how it goes because I just switched. I don't know, a few months ago. Luckily, like the bulk of what I needed done is done, and now it's just healing. I did not require for now or any chemotherapy or radiation because it was stage one. They said that basically surveillance after the surgery, the resection. So
Yeah,
that's
and for people who aren't aware too, what you underwent was not a simple surgery. This was they literally took out a good chunk, let's say, of your colon, created like that little blind pouch, prayed it out, put a pouch on top of that, and then for the other portion that was still remaining, they literally had to tie it all together. And while that portion of the colon was healing, the stool was coming out into the pouch, and then they went back in, had that part reattached to the colon so that everything is now seamless on the inside. That's basically what Dr. Dhillon underwent here. And so it's hard to fathom that there isn't some form of pain, there isn't some form of long-term recovery from this. This isn't just like a simple, oh, I had my
yeah,
tonsils out and you're back 2 weeks later. Like this is,
yeah.
what is the expected recovery to back to getting you to 100%? Like, how long do they tell you it might take?
I think that I'm not the norm. I think most people feel like kind of back to basics by now. I think I just had like a more prolonged recovery. I know that the J pouch for maturity wise, like in terms of tolerating different foods and, bathroom frequency, that takes, I've read anywhere from like 18 to 24 months. And, but some people, it's sooner. Some people never adapt and they have to have it removed and they have to have a bag for they have to go back to that. So it's really individual, but I think the majority of patients do really well with the type of surgery I have. Actually, when I was reading about it before I had it done, I mean, everywhere, all the articles I was reading, they had like 90% or more patient satisfaction with this. Like, what in medicine has like 90% or more satisfaction with anything? So I was like, of course I'm going to do it. That's
Right.
great
Yeah, of
odds,
course. Yeah, why
So I
not?
think that it should, once everything's kind of healed and matured, I think that people just go on and they just live their life. And
Well, I guess what's the alternative? I mean, chemotherapy and radiation, but I mean, you're not, I don't know what the success rate of that is. Was that ever
oh,
discussed? Like, was that ever
that
an
wasn't
option?
even, no, because just the type I had, it was so small. And I think that surgery is the standard of care for what I had going on. I think that that really wasn't an option for where I was at. And the
Hmm.
history of IBD is just, they have to take everything because if you have it there, you're probably going to get it somewhere else. If not today, maybe 5 years or whatever,
Right.
some arbitrary amount of time later.
And not for nothing, you're young and healthy enough that surgery recovery now is a lot easier than it might be in 10
Yeah.
years or 15 years.
Yeah. And it was done fully robotically. So I think that's why like the first surgery I healed so fast. Like, I mean, I didn't really have any pain. I just was like really good. I mean, you have like the first, couple weeks are a little rough because,
Hmm.
it's even just having small little incisions and it was a big surgery. So I think the first 2 weeks was just standard like any other abdominal surgery. It was, had some pain, but it was totally managed. It wasn't
Hmm.
anything. I think that the hard part was because I had a loop ileostomy in the beginning, the temporary one. So there was a lot of like skin irritation and like where they, have the adhesions around or the adhesive from like the bags and stuff. And so that was difficult to deal with, but that wasn't really a surgical problem.
Yeah. Let me ask you this question. Did you talk about this, if you talked about it with your children? Because your children at the time were, you had a 1-year-old, obviously, whatever.
So he was actually 2 at the
He was,
time.
okay.
Yeah, he
So
was
he was
2.
2 at the time.
Hmm.
And then and your children was 5 at the time. So he was a little bit
Yes.
more aware on
Yes.
what's going on. So how did you approach that conversation, if you approached that conversation at all?
Well, to be honest, I don't think that they understood. They just were not aware enough to understand the word and what cancer even means.
Sure.
So it was just, mommy has an owie. That's all I would say. And they were very receptive to that. And they were very gentle. They didn't, they're little boys. So they're obviously have a lot of energy, but they're always like really careful around me after the surgery. Like, oh, mommy has an owie on her stomach. We got to be careful. So it was basically just that. It wasn't, I did not paint like a doom and gloom kind of thing.
Yeah.
I tried to keep it light, but they unfortunately they do see the sides of cancer that with the emotional side, it's hard to keep things together sometimes. So I'm sure that hopefully I didn't totally ruin
Hopefully
them.
to make a core memory, that's,
I know. We tried our best, like to shield them as much as we could. We definitely
yeah.
tried our best.
I know when my cousin had breast cancer, I had her on the show back in the fall. They were much older. They were approaching, middle school age, teenage years. So they were much more aware of what was going on with their mom. And,
Yeah.
there was a discussion where they had to sit down and say, hey, I have cancer, this is the treatments. I'm going to look like this. And for
Hmm.
them, it's a lot of preparation. Like, I'm going to look different. I'm going to lose some of my hair. For her, it was breast cancer. So, and she went through a double mastectomy. And it was actually prophylactic in a way because of
Uh-huh.
the type of cancer. So, there's a lot of like, preparation before it happened, which I think it's not easy, but it made it easier for, things that kind of happen at home too. And you, I think, says in yourself in the article, which I want to pull up your article real quick here. All right. So, and you say it here, when you're a parent, when you're a parent, fear changes. It's not only instinct to survive, it's the immediate mental health of what their lives look what their lives would look like without you. And I think it was a very interesting quote because people also assume that we as physicians immediately just look to the medical side. It's very analytical. It's very, you know, basic scientific, but that's not the case.
Right.
Anytime we have these diagnoses, it becomes like we feel the same weight on ourselves as much as a patient does, especially when we have families. Did your medical knowledge, your medical training reassure you about what's going to happen, or were you more concerned than you think than the average patient? Like, what was your mental state at the time?
I think that for me, I sometimes knowing too much is like not the greatest. I think that it's easy for your mind to travel to like worst case scenarios. And in the beginning, like I said, I didn't know it was all signs were pointing towards stage 1, but I didn't know until I had the final path. So, and that took time because I had to wait from basically diagnosis until I had the final path. It was, kind of a while. It was like, I don't know, 6 weeks or 8 weeks or something. And that's it was felt like an eternity because it was either going to be like stage 1 or stage 3. Because if the lymph nodes came back positive, which thankfully none of them did. So I think that's where, obviously if you're a higher stage, you have higher rates of recurrence and things like that. So, you just worry like, oh, I hope that doesn't happen. And obviously, so but I don't think that we're immune to, sometimes people think, oh, well, like, she's a doctor, then she'll know all the stats and that will offer reassurance. And while maybe a little bit, but you're still human and it still is really impactful and scary.
What if there's anything that you can say to somebody listening to this that's scared of getting screened, who has colon cancer, is scared of the treatment? Is there any message you can offer them or anything you can share that might, I don't know, anything you want to say
Yeah.
to them?
I feel that, it's better the sooner you can catch something, the better. It is, it's nobody wants to get these, colonoscopies are not fun, but they're really quick. They're not that bad. I think the prep is the worst part. I mean, the actual procedure itself is not that long and, you're sedated. You wake up from like a nap. It's easy to put your head in the sand, but, sometimes you just have to go through it. You're going to go through it no matter what, whether it's going to be whatever stage it is. So it's better to know sooner than later.
Yeah.
You have better outcomes if it's caught sooner.
And I would say research your condition once you have a diagnosis, because I often say your patients will know their disease better than you will,
Yeah.
because now they have to live with this. So they're going to do all
Right.
the research. They're going to look into this. And, I would tell other physicians who are listening to this, don't be afraid of the patient who knows their condition too.
Sure.
If you are going to have somebody who with a life-threatening diagnosis or a chronic diagnosis, give them resources, give them information, and let them research it, because oftentimes that reduces fear of the condition itself, being aware of what's going on too.
Yeah. And even support groups, I think, would be great because, especially for some of the more rare illnesses or unique surgeries that maybe are not done a lot, like a lot of people don't know about. Like for mine, having this J pouch is kind of unique. I mean, a lot of people have them. I just wasn't really aware until it happened to me. But they have these, forums like on Facebook where it's like, people with the same condition. It's very helpful to have that kind of support. So I think even like for like different physicians that have, maybe practices that have unique illnesses to have, see if they have patients that are willing to have, like be part of a support group. I'm sure
Mhm.
that they probably would,
Yeah.
especially in their local areas.
Yeah. Get togethers, things that you can just share stories about how you're doing. You don't feel alone and
Yeah.
isolated.
Yeah, it
So,
doesn't have to be some like social media thing. It can just be something private like, oh, there's a group of patients that have similar and, here's a contact and they meet up every once in a while or maybe they don't meet up, but it's just somebody that you can talk to.
yeah, exactly. Well, Dr. Kristina Dhillon, thank you so much for coming on, telling us your
Yeah.
story. For those interested in reading the entire story on Forbes, I am going to link it into the description. You can find it on YouTube or on Apple Podcasts. Now that if you go into the actual description of the episode itself. So, Christina, thank you so much for coming on. It was great to see
Yes.
you.
It was great to see you. We'll catch up soon.
Thanks again to Dr. Kristina Dhillon for coming onto the show to discuss her personal story with combating colon cancer. Her story with ulcerative colitis was a very unique case. She was getting screenings yearly for some time, and then every 2 years once her disease became a little bit more managed. But even then, she still developed cancer, and she is at high risk for it because of her illness. And as I said in the introduction, not everybody's story with colon cancer is going to be the same. Prevention truly is the key to combating this disease. Treatments are available. But oftentimes, when people develop symptoms, it's already too late. You need to have routine screening starting at the age of 45 or younger, depending on your own individual risk factors. If you have questions or concerns about your own personal risk factors, talk to your own doctor, reach out to a GI specialist for further information, and they can better guide you on the treatment regimen and screening tools right for you. As I said, I'm going to link Dr. Dillon's Forbes interview into the comment section below. Give it a read yourself. An ounce of prevention truly is worth more than a pound of cure. Take this disease seriously and get tested, get screened, and talk to your friends and family about doing the same if you know they are overdue for their colonoscopy. As always, be safe, make good choices, and we'll see you next time.